Welcome to the second session of the Community Choice Track at the 2020 MDF Conference. My name is Bill Nuttall, and I am a co-facilitator of the chats every Tuesday night on Facebook. It is my pleasure to introduce to you our next incredible speaker, Dr. Leila Neshatian. She will be speaking with us about gastrointestinal concerns with myotonic dystrophy. She'll provide an overview of gastrointestinal health as it relates to myotonic dystrophy, including diagnostic testing, treatment options, and therapies. Dr. Neshatian is a neurogastroenterologist and Gastrointestinal Director at Stanford University in the Division of Gastroenterology and Hepatology. Her clinical areas of expertise and research include functional gastrointestinal and motility disorders. Thank you for joining us today, Dr. Neshatian. Please go ahead and take it away.
Okay, thank you for the kind introduction and invitation from Myotonic Dystrophy Foundation. I have great memories from 2018 Nashville MDF conference, and I miss seeing you guys in person, but I'm hoping that this is going to be something that is going to be useful for you, and looking forward to the future conferences to meet you in person. Today, I will be covering some of the common GI symptoms that are reported by patients who have myotonic dystrophy. I will try to explain you why these symptoms are seen, how can we make the diagnosis for each specific problem, and what are some of the medications and interventions that are available to help alleviate the symptoms. So let's start with this review of the anatomy of the GI tract or gut. As you can see here, the GI tract is a very muscular and tubular long organ that starts in the mouth. And after the mouth and throat, you will have the esophagus, which is the part in the chest, has two valves, one in the upper esophagus and one in the lower esophagus before the stomach. So these valves are very important. They are called the sphincter, and they will keep the food and the content to be backflowed. And so they keep the esophagus tight. After the esophagus, we have the stomach. Stomach is a very muscular and strong, basically, container. It has a lot of juices and enzymes. Through the contractions of the stomach with the food getting mixed with the enzymes and the acid, it helps that the food particles become very small. And when they are really small, they can be passed to the small bowel. In the small bowel, which is a very long, 20 to 30 feet long of an organ, through the surface of the small bowel, the food and minerals, vitamins, all the nutrients and water will get absorbed to the body. And this is where the majority of the absorption of the food and nutrients will happen. And then finally, food, which is really more of a liquid content, will get to the colon or the large bowel or the large intestine, and this is the part where the water will be absorbed into the body. And finally, the content, now it's called stool, will be stored in the rectum and get out of the body through the anus. So if you look at the cross-section of the gut, you can see there are many layers, starting from the innermost being the epithelial level, what we call, and this is where the absorption of the nutrients will happen. Then there are two major layers of the muscles that are important for the motility or contraction of the gut. And there are a lot of nerves also controlling the contractions, controlling the secretions, and controlling the function of the GI tract. So as you can see, there are a lot of nerves and muscles in this very sophisticated organ and are very important for their function. And in patients with myotonic dystrophy, the abnormal function of these nerves and the muscles will cause a lot of GI symptoms. And we know that these GI symptoms are reported in up to 60% of our patients who have suffered from myotonic dystrophy. And they can be, if even present in a patient before the muscular weakness happen, and there is no correlation between these symptoms and the muscular dystrophy or myotonic dystrophy and muscle weakness. So they can be much worse than the weakness in the muscles and be very bothersome. In a study where majority of the patients had myotonic dystrophy type 1 and some patients had myotonic type 2, we looked at the GI symptoms and what we have learned from our patients is that some patients here in type 1 shown in blue as compared to type 2 shown in yellow, it seems that patients with type 1, they have more symptoms related to abnormal swallowing, difficult swallowing, and patients who have type 2 have more prominent symptoms of constipation as compared to type 1. And it doesn't mean that the other subtype don't have those symptoms. It's just that the severity or the number of the patients who reported these symptoms seem to be different in each subtype of the myotonic dystrophy. And the symptoms of acid reflux, as you can see, was common in both subgroups of the myotonic dystrophy. And also there were a subgroup of patients who had problems with the gallstone and gallbladder problems, and only a fraction of our patients with myotonic dystrophy has symptoms related to abnormal liver enzymes and liver problems or true stomach ulcer. Here at Stanford, Dr. Day's group looked at the severity of the symptoms in our patients who have myotonic dystrophy. And it seems that some of the GI symptoms, such as abdominal pain, can be mildly symptomatic, and really diarrhea was not really truly bothersome with the major symptoms in our patients with myotonic dystrophy. But on the other hand, many other symptoms, such as constipation, gas and bloating, symptoms related to the problem with the fecal incontinence, nausea, vomiting, and as well as acid reflux, they were quite symptomatic. They were quite problematic in our patients. And the most severe symptom seems to be related to difficulty with swallowing. So knowing that, let's talk about each individual problem in the GI tract, starting from the mouth. So both muscle weakness and myotonia are responsible for problems with swallowing. And the difficulty with swallowing in medicine is called dysphagia. Dysphagia means that it takes longer and more effort for one to send the stuff from mouth to the stomach. So there are two levels of the dysphagia, one related to the oropharyngeal dysphagia, or the initial phase of the swallowing. And the second part is where the problem is with the esophagus. So in patients with myotonic dystrophy, the initial phase of the swallowing or the oropharyngeal swallowing can be very problematic. This will be involving the problem with chewing and preparing the food in the mouth and moving the food and liquids in the oral cavity by pushing through the throat by your tongue, and also at the pharyngeal phase, where the swallowing of the food and liquid is responsible for pushing the fluid from the throat to the esophagus. They all can be very difficult because of the myotonia. In the patients who have esophageal dysphagia, and many of our patients with myotonic dystrophy, the problem is with the contractions in the esophagus being weak. So the food doesn't really get movement in the esophagus to get to the stomach. And it's commonly causing the sensation of the food getting hung up in the middle of the chest or at the base of the throat. Why do we care about dysphagia in patients with myotonic dystrophy? It's because both oropharyngeal and esophageal dysphagia are known to be causing problems with aspiration pneumonia, which is really a severe problem and needs significant attention. So on the other hand, we know that many of our patients who have myotonic dystrophy will not really perceive their symptoms of dysphagia until it's really quite advanced. So it's important for us to talk about it, know about it, discuss this with our doctors, and really to try to prevent complications such as aspiration that can happen with the problems with dysphagia. How do we make the diagnosis? We often, for looking at the problems with the initial phase of the swallow, we use the modified barium swallow. This is looking at how you swallow different liquids and food through the initial phase. It's usually using a small amount of the barium for lightening up in the x-ray, and the doctor watches how you swallow different items with different consistency and thickness through the esophagus, and we'll observe where is the problem, and based on that we can provide recommendations on what to do. So sometimes we extend this swallowing to the esophagus, and also we look at the esophagus to see how bad are the abnormal contractions in the esophagus. And for evaluating the esophagus, we can also do esophageal manometry. Manometry is the test that shows whether your esophagus is working properly. Here, we have a very small flexible tube that we call it catheter, pass through the nose, through the stomach, and we ask you to have different swallows, and we look at the contractions that can happen in the esophagus. They are looking at the strength of these contractions as well as the coordination of these contractions. And if there are abnormalities, we can clearly see and help you to basically improve that. And in patients who have myotonic dystrophy, it seems that we know that majority of our patients have weak swallowing, both at the initiation of the swallow and the upper esophageal sphincter, or that valve at the upper, seems to be a little bit more relaxed, and also the contractions are weaker in the body of the esophagus, and the weaker contractions can cause the problems with the swallowing as well. So what do we do to treat our patients who have dysphagia? For oropharyngeal dysphagia, the doctor may refer you to see a speech or swallowing therapist or occupational therapist. They can be very helpful in teaching you the swallowing techniques and the certain exercises that can help coordinating swallowing muscles or triggering the swallowing initial phase. And they can be very effective in improving the symptoms. Also, always management will include modification of the diet and use of the different consistencies for better and easier swallowing. Avoiding thin liquids can be sometimes necessary to prevent the symptoms related to dysphagia. And finally, there are some subtype of our patients who have absolutely no ability to swallow, and we will be thinking about using the feeding tube and placing the feeding tube through the GI tract from the skin is going to be a good option to provide nutrients. It's an easy procedure. It's requiring doing an endoscopy or going with a camera with a tube down to the stomach to find the proper place and place the tube. Usually the tube can be used the same day, and no concerns over the procedure. Moving on, let's talk about acid reflux. As I told you, it's commonly seen in patients with myotonic dystrophy in up to 40% of our patients, which is much higher than the comparable population, which is somewhere around 20-25% of the population. The problem here is because of the laxity of the valve that is at the lower end of the esophagus, the food content can be, including the acid, could be basically pushed back up into the esophagus and cause the symptoms that are basically chest pain, heartburn, acid regurgitation, and can be very uncomfortable and give you a lot of discomfort. So in order to evaluate someone who is complaining of symptoms of heartburn and acid reflux, we often offer upper endoscopy. You may hear it as EGD, which stands for Esophagogastroduodenoscopy. Here we examine the lining of the esophagus, the stomach, and the first part of the small bowel, which is called the duodenum. So here we usually have the anesthesiologist to help us put our patients to sleep so that they are going to be comfortable for the procedure. We take this long tube that is the endoscope, and there is a camera at the tip of it to go through this the mouth and examine the GI tract. And if there are any inflammation, clearly we can see the inflammation. Sometimes we do biopsy to also further evaluate the tissue. But the treatment of the esophageal reflux usually requires, again, a lifestyle modification, dietary modification, avoiding the spicy food, fatty food. Alcohol and caffeine can be very effective. We ask our patients to stay upright after they have a meal for at least like 3 to 4 hours, and don't go to bed or on a recliner. That is going to be basically facilitating more of the acid reflux when the stomach is full. Also, at the time that they go to bed, we want to raise the head of the bed at 30 degrees. It's usually by putting a couple of bricks at the bed head, or sometimes we ask to use the wedges that are commercially available and help to keep you more propped up. So if these lifestyle modifications are not ideally alleviating the symptoms, then we can use the medications. There are two major groups of medications that are available. One is working on the histamine channels, and so the histamine blockers are going to be very effective. The two that are available in the market, commonly used over the counter, also ranitidine and famotidine. But I want to tell you that FDA has requested all ranitidine, you may know it as Zantac, to be pulled from the market earlier this year. And the reason is because of the concerns over the possibility of the medications having some ingredients to be carcinogen. So we want you to stop taking ranitidine, whether this is something that was ordered by your medical doctor or whether you got it from the over the counter. If you are on Zantac, we want you to change it with famotidine or other medications that can help you. The other medications that are commonly used are called proton pump inhibitors. They are very effective in blocking any acid in the stomach. They are also available both in the form of the over-the-counter or through the prescription, and you may get it from your doctors. Moving on to the stomach, I want to talk to you about delayed gastric emptying, or what we call gastroparesis. Gastroparesis is a disease in which the stomach cannot empty itself of food in a normal fashion. So the stomach, as you saw, is through the contractions pushing the food to the small bowel. And if these contractions are impaired and are floppy, basically this is what we see to cause abnormal or delay in the gastric emptying. And the symptoms that we hear commonly from our patients include some degree of nausea, vomiting, abnormal with feeling full quickly after they eat, and sometimes heartburn as well. How do we diagnose the gastric emptying problems? We ask you to do the gastric emptying scintigraphy. Here is a study that determines the time that it takes for a meal to move through the stomach to the small bowel. We provide the standard meal for this nuclear medicine study. This study will, you will be required to have a breakfast or the meal that is containing 4 ounces of egg beaters scrambled and 2 pieces of toast with some jelly, as well as 6 ounces of water. There will be some radioactive isotope in the scrambled egg. Doesn't have a taste, but it will allow us to see identify the emptying in the stomach. It's usually 4 hours of the study. There will be images at 0 time right after you finish this meal, and then 1 hour, 2 hour, and 4 hours after you have the meal. And this will allow us to see, as you can see in the images, to see how long will it take for the food to empty the stomach. So how do we treat the gastroparesis? Again, the diet has really a huge role. The purpose of the diet for gastroparesis is to reduce the symptoms and maintain adequate nutrition. The nutrition goals are to stay hydrated and provide calories, minerals, and essentials. Vitamins also for you, and every person may have a different requirement, and working with a nutritionist can be very effective in improving the diet and nutrition. So the general dietary recommendation that we also provide as a general rule, we want you to be on basically low fat, low fiber diet, have smaller meals but more frequent, so that we ensure you're having enough nutrition. You are having enough nutrition through the smaller meals more frequently. If the treatment with the diet is not sufficient, we often use medications. The medications are either to enhance the GI motility, what we call the prokinetics or promotility agents, and they help with the strength and duration of the contractions, and cause the contents of the stomach to empty faster and more properly. There are different medications here. Metoclopramide, you may know it as Reglan. Domperidone is not FDA approved, but can be used in certain patients. There are the 2 antibiotics, azithromycin and erythromycin, that can be used. All these medications, there are some concerns with the arrhythmias, and so we have to be very careful with their use. Nostigmin is working on the contractions. This is another way of improving the motility as well. Also, because the nausea can be very prominent in our patients, we often use the anti-nausea medications, and these are really not to improve the gastric emptying, but to alleviate the symptoms related to the delayed gastric emptying with prominent nausea. And again, if you look at the patients with myotonic dystrophy, it seems that Reglan or metoclopramide seem to be very effective in improving the gastric emptying in our patients with myotonic dystrophy. Erythromycin in a smaller trial showed there was some benefit into it, although not maybe as effective as we wished for it to be, but definitely can be used. And if these medical options do not provide optimal response, then we will move on to use the surgery. The different surgeries that are available, and there are no data really on myotonic dystrophy patients, are going to be providing the feeding tube. Again, like remember that feeding tube here has to bypass the stomach because the stomach doesn't really empty well. So we want to place the feeding tube in the small bowel. This is usually done by the surgery group here. The gastroenterologist cannot really, all of them cannot really provide this. The other good surgery in some people for prominent nausea, we can use a gastric pacemaker. Gastric pacemaker is surgically implanted under the skin near the stomach. There are two leads, electrodes that are going to be placed in the stomach. They enhance the contractility of the stomach and improve with the emptying. Has shown some benefit in patients who have gastroparesis. And finally, we can also think about like doing the surgery with cutting the outlet of the stomach to make the flow easier by having no resistance at the end of the stomach. Moving on, let's get to the small bowel. One of the conditions that have been reported by patients with myotonic dystrophy is chronic intestinal pseudo-obstruction. It is caused by nerve or muscle problems that prevent the intestine or the bowel from contracting normally to move the food and fluid and air through the bowel. So symptoms here are usually with abdominal cramping, abdominal bloating, nausea, vomiting, and constipation. And very rare occasions, you may see some degree of diarrhea as well. And so it can be very significantly bothersome with the distension of the abdomen. As you can see in this picture, the X-ray will show really dilated bowel loops. And this is usually what we see in people who have true mechanical obstruction. But here there is no mechanical obstruction. That's why it's called the pseudo-obstruction, because there is not really a truly something that is obstructing the bowel. And so when we treat these our patients, we want to make sure that we don't send them for surgery. We don't mistake these with a true mechanical obstruction, because the surgery is not going to be helpful. And the main treatment is nutritional support to prevent malnutrition and use of the antibiotics to basically address the abnormal bacteria that can be growing in the gut in these situations. Sometimes we use those prokinetic, the agents that improve the contractions, also with some degree of benefit. I have put the list of all these medications again here, and they can be tried with various degree of success in some of our patients. Moving on to the subject of constipation. Constipation, most of us know constipation as infrequent bowel movements. If you have less than 3 bowel movements in a week, we consider that constipation, which is a valid definition for constipation. Some patients with constipation have very hard and lumpy stools. But other than these symptoms, also if someone has multiple bowel movements in a day, but they have significant need for straining, they have the sensation that they can't get empty their rectum, and there's a blockage at the rectum that prevents them from having proper bowel movement. Or in some extreme cases, some of our patients may need to use their hand to help with evacuation of the rectum. So all these symptoms, even if it's not really infrequent bowel movements, are consistent with the diagnosis of constipation. Looking at the stool chart, the Bristol stool chart, you may have seen it if you have seen a gastroenterologist, have different the levels of the stool forms. And as you can see in type 1, 2, 3, the stools are hard and lumpy. And so these are more consistent with the diagnosis of constipation. The stool that is type 4 is the ideal stool. It's a snake-like, really smooth and easy to evacuate bowel movement. And patients who have diarrhea often report like more type 5, 6, and 7, which is the watery diarrhea. So your doctor may ask you to describe your stool, but they will be really looking for these 7 subtypes. Let me remind you of how we have a proper bowel movement, how we poop. So here, when the food or the stool gets to the rectum, is stored in the rectum. But at this point, most of us will get the urge for having a bowel movement. And if this environment is appropriate, we will get the proper posture, increase intra-abdominal pressures and increase the pressure in the rectum to push the stool down through the anus. But the anus is usually kept closed tightly by the muscles, including the puborectalis, which is this sling U-shaped muscle here, the external and internal anal sphincters. And these are important muscles to keep us continent of passing the stool. So when we are trying to have a bowel movement, we need all these muscles to relax. Then the push in the rectum will get the proper evacuation of the stool. If any of these don't happen normally, if the rectum doesn't have normal pushes, or if these muscles of the anal sphincter don't normally relax and don't have proper relaxation, there is going to be problem with evacuation, with constipation, and causing problems with defecation. So in patients with myotonic dystrophy, it seems that problems with relaxation of the pelvic floor muscles, anal sphincters, and puborectalis is very commonly reported. And as you can see, myotonia in these muscles can prevent proper relaxation of these muscles. And this is causing what we call pelvic floor dysfunction. And this is a good cause of constipation in more than 90% of our patients who have myotonic dystrophy. And so this is where the problem is. But also, it seems that in 25% of our patients with myotonic dystrophy, there's also some degree of abnormal contractions in the colon, what we call slow transit constipation, that is sometimes overlapping with the pelvic floor dysfunction. Also, there are some group of our patients with myotonic dystrophy who have irritable bowel syndrome with constipation predominant symptoms. So remember that in irritable bowel syndrome, patients who have constipation, they complain a lot of abdominal symptoms. It can be abdominal pain, abdominal bloating, but these prominent symptoms are basically, along with the constipation, take us to make the diagnosis of irritable bowel syndrome with predominant constipation. So the other abnormal problem that can happen with the patients who have myotonic dystrophy is fecal incontinence. Fecal incontinence is the inability to control your bowel movements, causing the stool to leak unexpectedly from the rectum. So it can range from occasional small amount of stool that can leak out, or it can be prominent and complete bowel loss can happen as well. The causes of fecal incontinence in patients who have myotonic dystrophy is usually because of the pelvic floor muscles and nerves being damaged because of the myotonic dystrophy. And also, I must say that the abnormal bowel with the diarrhea and constipation can also predispose one to have more of the abnormal leakage from the rectum. We know that in myotonic dystrophy, the pelvic floor muscles are usually thinned, and is part of the muscle wasting that is seen as part of the myotonia. And this is basically causing some degree of problems in our patients. So the other common cause of fecal leakage in patients with myotonic dystrophy can be rectal impaction or the fecal impaction. Fecal impaction happens when there is a large hard mass of a stool is stuck in the rectum. And this prevents the normal flow of the stool out of the rectum, and only the liquid stool can be really sipped or leaked out of of the rectum from around this rectal mass. And here, for the symptoms of the fecal leakage, we should really be cautious with the use of the antidiuretic medications, because that's going to make the situation worse. And the treatment will involve using the enemas to get this rectal mass dissolve and come out, so that the leakage will improve after this is done. But for evaluation of our patients who have any of these symptoms of constipation or fecal incontinence, we often use anorectal manometry. Anorectal manometry is a test that is performed to evaluate the function of the muscles that are related, anal sphincters that are related for proper evacuation, and measures the sensitivity and sensation at the level of the rectum as well. So here, a very small, flexible tube, like a pen, will be inserted in the rectum. There's going to be a party balloon at the tip of it that is going to be helping us to get the sensory levels after inflation in the rectum. This test is very easily done. There is no need for prep and no need for sedation. It's unpainful, usually for 20 minutes. For evaluation of patients who have slow transit, or we think about like the lousy colon being a problem, we can use the capsule studies. There are two forms of the capsules currently available. One is the very easy small capsule with 24 markers, tiny markers in it. We ask our patients to swallow that. 5 days later, we get an x-ray. We count the number of these markers that are left in the abdomen after 5 days. And if more than 20% of these markers are still in the stomach, in the bowel or the colon, we consider this as a marker for slow colonic transit. The other tests require a more sophisticated, but also a much more bigger capsule swallowing. So we have to be careful because it's a big capsule to be swallowed. And this novel gadget will measure pH, temperature, and contractions throughout the GI tract as it goes travels through the gut, and we can understand better of the contractions and the transit time for each piece of the GI tract, whether this is the stomach, small bowel, or the colon, and determine difficulty with the motility as well. So for patients who have abnormal evacuation and constipation or fecal incontinence, we usually go with lifestyle modification. We ask for a diet that is rich in fiber, and we make sure that they are having enough fluid. Hydration is going to be very important. We ask for exercise, and it might be very limited in a patient who have advanced myotonic dystrophy, but it's still as much as tolerated. It's going to be really encouraged. It's going to be very effective in improving your GI health. Also, breathing exercises that can be easily done are very effective in improving also the evacuation, and defecation can be very helped with the proper use of the diaphragmatic muscles. Sometimes we ask our patients to use the squatty potty if it's safe for them and it doesn't put them at risk of fall. This is a step stool that goes easily under the commode or your toilet. It helps with raising the knees and the hip. And so if you remember this picture of the pelvic floor muscles, by raising and squatting, this will allow the angle that is between the rectum and the anal canal straighten up, so the relaxation of the muscles of the pelvic floor is going to be easier. Evacuation can be very effective, and I hear from our patients that this can be very helpful in easing defecation in some of our patients. I want to talk to you about the fiber because it's a very common question. I know you will get the whole session on nutrition, but just to remind you that fiber is very effective in improving the GI health by providing some level of the probiotics. It's also very important to know that the soluble fiber is going to be more effective in improving the symptoms related to constipation as compared to the insoluble fiber. But if you take too much of fiber, more than 30 gram of fiber a day, if you combine the supplement plus what you have in your diet, it can be a problem with abnormal bloating and worsening of the GI symptoms. So you have to be careful in how much fiber you take and don't go overboard with that. In terms of the laxatives that we often use for patients, we want to use a logical stepwise manner in ordering the laxatives. Often we start with the stool softeners. They are providing some lubrication, but they are not as effective per se. Osmotic laxatives, they are drawing the water to the lumen of the GI tract. They are very effective. Polyethylene glycol, you may know it as Miralax, that can be very effective. Magnesium lactulose, these are very effective in management of the constipation. If they are not enough, we can move on to use the stimulant laxatives. These are like bisacodyl, or you may know it as Dulcolax and Senna, or the tea bags usually have Senna as well. They are very effective in contractions, improving the contractions in the colon and improving the basically constipation symptoms. If they are not sufficient, then still symptoms are prominent, we can use the newer prescription medications. The two major groups that have been in the market and over the past couple of years or a decade now are pro-secretory agents. These medications, the three of them under lubiprostone or Amitiza, linaclotide or Linzess, and plecanatide or Trulance are important for drawing the water to the lumen of the GI tract. So the stool is going to become much softer. Sometimes diarrhea can be a problem with them. The prokinetics, again, remind you that these are the medications that help with the contractions. The two that have been recently approved in the US market are Tegoserad or Zelnorm and Prucalopride or Motility. They can be also used for our patients with myotonic dystrophy with cautious as well. So sometimes along with all these dietary modification and laxative use, we ask our patients to also see a pelvic floor physical therapist who can help them with the techniques that can improve the defecation, to learn how to strengthen the muscles of the pelvic floor to prevent fecal incontinence, and how to relax these pelvic floor muscles, how to use the technique that help with the bowel evacuation as well. Let's talk about the diarrhea. There are a couple of causes for diarrhea in patients with myotonic dystrophy. The more important one is going to be small intestinal bacterial overgrowth, or SIBO. This is common. Up to 65% of patients with myotonic dystrophy may see that. It's because of the abnormal motility of the small bowel. So the bacteria that is normally seen in the colon can go to the small bowel, and it will cause the symptoms with abdominal bloating, abdominal cramping, as well as the diarrhea, and weight loss can happen. Usually the diagnosis is through basically blowing the breath. We gather the breath in the plastic bag. After, we ask you to have some sugar ingestion, and this will allow us to make the diagnosis. And treatment is usually requiring antibiotics, and sometimes rotating multiple doses of the antibiotics every couple of weeks will be required. Some patients have, again here, irritable bowel syndrome, meaning that they have prominent abdominal cramping and bloating with relationship to the diarrhea. And this is because of abnormal function of the nerves and muscles of the GI tract. But here, rather than constipation, the prominent symptoms is diarrhea. So we call it IBS. With the diarrhea predominant symptoms, we can use anti-diarrheal medications such as Imodium for our patients safely to prevent the symptoms. Bile salt malabsorption is a condition that occurs when your intestine cannot absorb the bile acid properly. So this bile will get to the GI tract and cause watery diarrhea. The bile is really naturally made in the liver and stored in the gallbladder. We know that the problems with the gallbladder is common in our patients with myotonic dystrophy. Up to 50% of our patients have reported gallstone problems. And this is because of the abnormal contractions, the motility of the gallbladder, which is like a container for the bile. And when gallstones happen, they can become symptomatic with having pain and cramping after having especially a fatty meal, and treatment is easy. It's a day surgery. We'll remove the gallbladder through the surgery, and this is gonna alleviate the symptoms, although some degree of diarrhea can happen after that. So as you could see, many of these symptoms related to abnormal function of the gastric emptying or gastroparesis, small intestinal bacterial overgrowth, abdominal constipation, gallstone, and small intestinal pseudo-obstruction can cause prominent symptoms of pain. And here the treatment should be really focused on addressing the underlying problem and treat the targeted pathology. But in all of these, there are some certain themes that can help with the alleviation of the pain as well, including the dietary modification, use of the antispasmodics that can relax the bowel and basically improve the cramping that can happen. The neuromodulators that are affecting the nerves and basically numb the nerves can be helpful. And in patients with myotonic dystrophy, it seems that the mexiletine has been tried with some degree of success in alleviating the abnormal myotonia and contractions in the GI tract as well. So in summary, myotonic dystrophy can affect the GI tract from mouth to the anus. GI symptoms are common in patients with myotonic dystrophy. A variety of motility and diagnostic tests are available for assessment of the GI symptoms in our patients. Most of the GI symptoms are amenable to treatment, and treatment of the GI symptoms will improve quality of life in our patients with myotonic dystrophy. With that, I want to thank you, and I'm here ready for all your questions. Thank you for your attention.